Hi, friends. Yesterday, I was talking about the general aspects and etopathogenesis of RPL. I was talking about the causes and was telling that there are only two clearly well-known or undisputed causes, that is the parental chromosomal problems, and number two is the acquired thrombophilias. Then there are other causes like anatomical, hormonal, immunological, and lifestyle causes. I was explaining the NK cells and the causes due to that. And at this slide, we got stuck. I will start from there. For a successful pregnancy, there should be a perfect balance between Th1 and Th2 reactions. Th1 is a rejection reaction because of the peripheral NK cells, whereas Th2 is a facilitatory reaction. It is because of decidual NK cells and due to the presence of progesterone. The other one is due to the deficiency of progesterone. So in cases of RPL, the balance is tilted towards Th1 reaction, that is a rejection reaction. But having said that, Eshre does not recommend routine testing of NK cell panel because there is insufficient evidence to recommend NK cell testing of either peripheral blood or endometrial tissue in women with RPL. So let us now turn to the other factors, that is lifestyle factors. Obesity, smoking, alcohol, caffeine themselves increase the risk of RPL. This is the old concept, but the mechanism was not clear. As per the new concept, probably they modify non-lifestyle intrinsic factors. For example, smoking aggravates thrombophilic effect. That's why Eshre suggests that couples with RPL should be informed that maternal obesity or being significantly underweight is associated with obstetric complications and could have a negative impact on their chances of a live birth and on their general health. So their recommendation is striving for a healthy normal range BMI. As far as smoking, again, couples with RPL should be informed that smoking could have a negative impact on their chances of a live birth, and therefore, cessation of smoking is recommended. Other factors like stress. Stress has definitely an impact on general health, so also the pregnancy. It promotes RPL through psychoneuroimmunologic pathway, whatever it means, interferes with normal function of immune system, and increase in NK cells that promote Th1 reaction, that is the rejection type of reaction. So far, we have been blaming only the female factors, but now the research is going on on the male factors as well. RPL has long been considered as an issue stemming exclusively from female causes, but we know that if a man achieved pregnancy, his gametes were deemed normal. It is just deemed normal, but nobody has really done research on that. Because female factors only account for 50 to 60% of RPL, leaving 40 to 50% unexplained. Probably some of them could be male factors. Possible male factors have not been satisfactorily addressed or taken into account in these numbers. That's why Eshre now recommends in couples with RPL to assess lifestyle factors in the male partner, especially with regards to paternal age, paternal smoking, alcohol consumption, exercise pattern, and body weight. It, of course, requires further clarification and research. So, treatment, of course, in male factor problems could be changing lifestyle, and for couples having ICSI, the use of hyaluronan selection looks promising. Further studies, of course, are needed to confirm this. We have understood the different factors that can give rise to RPL, but we also should know which factors definitely do not cause RPL, because otherwise, when you read, you will read so. For example, exercise. Exercise do not cause RPL. Infections. We have given up testing for torch infections long back. Low level exposure to environmental chemicals and paternal HLA sharing. These do not cause RPL at all, so there is no point in wasting our time and energy. Let's now turn to what investigations to be done. It's very easy, having understood the definite causes and other causes. The investigations also will be accordingly listed. The first and foremost is history taking. Eshre gives a lot of importance for that. We have to take detailed history on menstrual cycles, breast secretions, because this will give us a clue towards the presence of PCOS and hyperprolactinemia. Remember, yesterday I was telling, Eshre suggests estimation of prolactin only if there are symptoms in the patient. Gestational age and character at the time of abortion is very important. If it were early abortions, then we can suspect chromosomal or hormonal problems. If it's a late abortion, then it is anatomical or immunological. There can be significant overlap in both. Congenital and karyotyping abnormalities may be inheritable, so we must ask history about that. Pulsations, if they were not seen, then it suggests chromosomal problem in the baby. Exposure to toxins and lifestyle will give us an idea whether the baby has had any lethal effects of that. Venous and arterial thrombosis will give us a clue towards APS, and previous lab or pathology or imaging history will give us a clue towards the cause of RPL. Now let us look at the actual investigations to be done, and very well-known investigations based on the very well-known causes. Number one, genetic. So we have to do karyotyping of the couple. I'm repeating, karyotyping of the couple, because to look for the balanced translocations in them. If you want to explain to the patient why the abortion occurred, then array comparative genomic hybridization can be done on the abortus. But that doesn't help us in predicting or preventing the RPL. Testing for APS is mandatory as per Eshre. In that, the very important one is ACA, that is anticardiolipin antibodies, LA, which could be PT, APTT, DRVVT, and KCT. Talking about the criteria to diagnose APS, if you only fall back on lab criteria, many times they could be normal. That's why the updated Sapporo criteria 2006 talks about clinical criteria as well. You must ask history of vascular thrombosis in the past or in the present, pregnancy morbidity in the past, especially if there was spontaneous abortion less than 10 weeks, one or more unexplained deaths of a morphologically normal fetus after 10 weeks, or one or more premature births of a morphologically normal fetus after 34 weeks due to severe preeclampsia or placental insufficiency. If any of these things are present, then clinically you can say that she definitely has a APS syndrome, because sometimes the lab criteria may not fit exactly into the diagnosis. However, the lab criteria is positive plasma levels of LA, ACA, both IgG and IgM, medium to high titers, that is more than 99th percentile. If you did anti-beta 2 glycoprotein 1, then the titers should be more than 99th percentile. And what is said is that the first testing should be done after 12 weeks of the abortion, and then they should be positive on 2 or more occasions with the evaluations 12 or more weeks apart. So I'll repeat, 12 weeks after the last abortion, and then the second testing is 12 weeks after the first test. So, in other words, a minimum gap of 6 months should be given after the previous abortion, unless the patient is very elderly and she has no time to lose, in which case I have seen some people do the first testing after 6 weeks and they don't repeat the test at all. So, after these known or well known investigations, we should also estimate the endocrine problems by doing TSH, GTT, and prolactin. As said earlier, prolactin only if the symptoms are present. TSH should be done even if the antibodies are present. As long as TSH is normal, we don't have to worry much. GTT is done instead of testing for insulin resistance. To evaluate the anatomical problems like septum and other things, ultrasound 2D or 3D is better. MRI, HSG, sonohistography tells about the interior of the uterus much better than any other. So it is better done in cases where you suspect the problems with the cavity. Hysterolaparoscopy is not just diagnostic, it is therapeutic as well. Not routinely done are more specific APS testing, that is anti-beta 2 glycoprotein 1, anti-phosphatidylserine, which inhibits trophoblastic invasion, ANA anti-double stranded DNA, and NK cell panel. I have already explained all these things. These are usually done in a research setting. It need not be done as a routine. What is definitely not recommended also should be known by us, like what definitely does not cause RPL. The investigation on progesterone levels and endometrial biopsy to diagnose LPD is definitely not recommended. Of course, endometrial biopsy is not been done for a long, long time now. Inhibin A and testing for sperm ploidy and embryotoxic factors and decidual cytokine profile, that is Th1 to Th2, and HLA-G polymorphism. These things are definitely not recommended as a routine investigation. So to summarize the investigations, what is currently practiced, I'll divide them as proven benefit. Number one is ACA, LA, karyotyping, ultrasound, TSH, and GTT. Potentially promising ones are anti-beta 2 glycoprotein 1, anti-phosphatidylserine, ANA, NK cell panel, and maybe prolactin in symptomatic patients. What are unproven, unnecessary, and misleading are extensive antibody panels, anti-paternal cytotoxic antibodies, mixed lymphocyte culture reactivity, leukocyte antibody, and HLA typing. So having understood the etopathogenesis and the investigations, now let us look at the management. Again, it's very easy because we already know what are the two important causes, what are the two important investigations, and definitely the management is directed towards them. The first one, again, karyotype abnormalities. Of course, here, nothing much can be done except that we can refer the patient to genetic counseling. If prenatal genetic studies show, that is after amniocentesis or granular sampling to determine the fetal karyotype, then the only option could be MTP if the fetus is affected. But the alternative for this would be, instead of allowing them to have spontaneous pregnancy and then going for prenatal genetic studies, nowadays IVF is offered so that we can do PGT and only transfer the healthy embryos and discard the unhealthy embryos. And if there is problem with all the embryos, then we have to advise oocyte donation or maybe a sperm donation. Oocyte donation is more important because most of the time the problems are with maternal side rather than on the paternal side. As I said, pre-implantation genetic testing can be used to avoid transferring of the implantation of an affected embryo. Gamete donation, as I was just mentioning, egg or sperm, mostly egg. Surrogacy, especially if the uterine problems are there, or adoption finally are the methods of preventing conception of an affected embryo. This is also recommended by Eshre. The second problem, APS, the treatment is very, very well time-tested treatment. It is heparin plus aspirin. As far as aspirin is concerned, it could be 75 mg to 100 mg per day. And with one or more fetal loss beyond 10 weeks, enoxaparin 1 milligram per kg twice daily. Whereas with pregnancy losses before 10 weeks, enoxaparin 1 milligram per kg only once daily. What Eshre suggests is that aspirin can be started before conception. The problem is we don't know for how long we should be giving because nobody can predict when exactly she's going to become pregnant. Probably something like pre-conceptional vitamin folic acid, we can start 3 months before the planned pregnancy. And as far as enoxaparin is concerned, it can be started at conception, maybe once you confirm the pulsations. Now, the newer concept is that to add immunomodulators, because if you remember in the beginning, I was talking about pregnancy is a situation of immunomodulation. So if there's a disturbance in immunomodulation, so in addition to heparin and aspirin, we can add immunomodulators. And how do they act? They act by decreasing production and increasing clearance of antibodies, complement the inactivation, and they suppress the Th1 cytokine production, T cell regulation and suppression of their adhesion to extracellular matrix. So immunomodulators have a big role in the treatment of recurrent pregnancy loss. What are these? One is IVIG. The problem with this is it's very, very expensive. Second one is progesterone. Now, progesterone, there's a lot of controversy in and around progesterone, but always progesterone is trying to make an entry in the treatment of their pregnancies, one or the other way. So this is making a backdoor entry, not as a hormone, but as an immunomodulator. Now, which progesterone to be given is another big controversy. It goes into so many lectures, but whichever is comfortable with you or with the patient can be given, starting from natural, that is injectable, or micronized, that is oral, or that could be dydrogesterone, which is also oral. Now, micronized can be available in vaginal suspensions, vaginal ointments, vaginal tablets, so many things. I am not going to talk into any one of those in detail. As far as testing and treatment of anti-nuclear antibodies, the popular treatment after IVIG is HCQ. Of course, HCQ is safe during pregnancy, but the truth is that the drugs have adverse effects and single devastating complication due to a medication of unproven benefit easily outweighs hundreds of cases of it might help. So we have to be cautious about that till the research clearly tells us a green signal, gives us a green signal. As far as the immunosuppression, which was done in the past by using steroids, it is not recommended anymore because it can produce noteworthy, increase the maternal complications and fetal complications. So also immunostimulation using maternal transfusion with either paternal lymphocytes or pooled donor white blood cells. This is also out of the treatment armamentarium. As far as hormonal treatment is concerned, if you prove there is problem, high TSH, then you can give thyroxine. Even if the thyroid antibodies are present, as long as TSH is normal, there is no need to give thyroxine. But if the TSH is very high, you must give thyroxine. Euthyroid women with thyroid antibodies should not be treated with levothyroxine. Hyperprolactinemia, of course, you have to treat them with cabergoline, which is once a week, and bromocriptine, which is daily treatment. As far as HbA1c being more than 6.5, a strict sugar control is very, very necessary pre as well as post-conception. not only for prevention of RPL, but also prevention of the anomalies. As far as PCOS with insulin resistance, there is insufficient evidence to recommend metformin to prevent RPL. But some studies have shown that continuation of metformin in the first trimester is going to prevent the abortion. If that is true, then it should prevent RPL as well. LPD, as I said, that is a controversial issue, both from the point of existence or association with RPL, as well as from the point of assessing it through a hormonal assay, that is progesterone estimation. And as far as treatment is concerned, there is insufficient evidence to recommend the use of progesterone or HCG to improve live birth rates. Now, I want to make a distinction here. Progesterone as a treatment for LPD is controversial. Progesterone as an immunomodulator is encouraged. What about anatomic corrections? Yes, definitely. If that is the cause of RPL, you have to take care of that. Especially septum resection is very beneficial. Metroplasty, of course, is not recommended at all by Eshre because that itself can cause problems once she becomes pregnant. There is a higher incidence of uterine rupture. Instead of that, surrogacy is a better option and it is a preferred option. Cerclage as a routine or as an empirical treatment has no proven benefit. Having said that, if the problem is due to cervical insufficiency, definitely a cerclage at 13 to 14 weeks is going to help. Submucous fibroid, again, it is controversial unless you think that submucous fibroid is in the area of implantation, that is the posterior wall of the uterus. And if it is occupying the entire cavity, then you may have to remove that. But otherwise, there is insufficient evidence that all fibroid should be removed. Again, the size matters. Any fibroid which is more than 4 to 5 centimeters or it is occupying the cavity should be removed. As far as infection is concerned, there is no evidence to say that it is associated with RPL. Obviously, there is no role for treating the infections. I'm talking about torch infections. So to summarize the treatment of RPL, again, I go into 3 categories. Proven benefits are seen with anticoagulation and immunomodulation. Potentially promising, as I said, IVIG immunomodulators, whether it is progesterone or HCG. Misleading, ineffective, and potentially dangerous ones, which are not at all beneficial, they can be harmful, is prednisone as well as leukocyte infusion therapy. To summarize what I said so far is that we can start investigating RPL after 2 losses. We need not wait for 3 losses. The mandatory testing, number 1 is anticardiolipin antibodies, lupus anticoagulant, transvaginal sonography, TSH, GTT, and of course, parental chromosomal studies. This should have come before ACA. Optional ones are anti-beta-2 glycoprotein 1, anti-nuclear antibodies, NK cell panels, phosphatidylserine. These are not routine. These are usually done in research setting. Beneficial treatment, again, one is genetic counseling if there is a chromosomal problem, or PGT and maybe surrogacy or egg donation. As far as the thrombogenic factors, aspirin and heparin with or without immunomodulators is definitely going to be helpful. TLC, that is either tender loving care or therapeutic lifestyle changes, definitely welcome. So to give a final verdict on RPL treatment, affected couples, often desperate for a solution, sometimes grasp at unproven or useless remedies. What they need instead is factual information, emotional support, and if possible, treatment based on medically established cause. Actually, I've finished with the RPL. As an extension, I'll go to unexplained RPL, which is like a juggernaut. As I said earlier, 50% of the RPL are unexplained. So the management options are, first, good news. What is that good news? There is a chance of a live birth very high chance of live birth, over 50% with no intervention in unexplained RPL. That means after 3 abortions, somehow the chance of successful pregnancy is up to 75%, even without treatment in unexplained RPL. I am repeatedly telling unexplained RPL. Then what are the possible treatment options? Again, we talk about lifestyle modification. They can increase fertility potential, although these have not been definitively tested by RCTs. Eliminating use of tobacco products, alcohol, caffeine, because these are there in RPL cause as well as unexplained RPL cause. Reduction in body mass index for obese women goes without saying. I come to IVF. Now, it's very difficult to explain and convince the patient of RPL the need of IVF because they will tell you, doctor, my problem is not infertility, my problem is not conceiving, but my problem is recurrent pregnancy loss. Yes, we know that, but probably that couple has chromosomal abnormalities, and every time they conceive, they may be going for the abortion, especially if there is 22 to 22 Robertsonian translocation. 100% of the time, they'll go for recurrent pregnancy loss. In such a case, we have to break that by only egg donation. So not only IVF, egg donation. Now, why IVF if there is no such problem? IVF because there's an opportunity to do PGT. And when we do PGT, we can avoid transferring the problematic embryo. So we can transfer only the good embryos. So IVF is not alone. IVF with PGT is offered for RPL. Embryos of women with unexplained RPL have higher incidence of aneuploidy for chromosomes 13, 16, 18, 21, 22, even X and Y. So than embryos obtained from healthy women. This is the logic behind offering IVF with PGT. However, the studies evaluating the value of IVF PGT in women with unexplained RPL have yielded mixed results. The second one is oocyte donation. I have already explained because of the poor quality oocyte, there can be RPL in 25% of the unexplained RPL. So ovum donation has been associated with a live birth rate of 88%. So the success of ovum donation, even when the male partner's sperm is utilized, suggests that absence of a significant paternal contribution to RPL. That's what I have been telling in the lecture, that it's only egg donation most of the time useful in RPL rather than the donor sperm. Donor sperm is done only in case of azoospermia. That is an infertility issue. Surrogacy. Again, why surrogacy? Patient will not understand. Patient thinks that I'm becoming pregnant, there's no problem. But surrogacy is basically to tackle when RPL or recurrent IVF implantation failures are not associated with recurrent embryonic aneuploidy. That means embryo is fine and obvious intrinsic gamete factors are also absent. So that means whom we should blame? We should blame the uterus. So that's where surrogacy is offered. What about aspirin? Again, aspirin here not as a against a thrombogenic phenomena. The trials, it is basically used to improve the blood supply to the uterus. What about low molecular weight heparin? Again, trials show no benefit of low molecular weight heparin in treatment without an inherited thrombophilia. So aspirin and heparin should not be given just like that unless you prove APS. What about HCG? Human coronary gonadotropin, to date, there is insufficient evidence to recommend the use of HCG to prevent pregnancy loss in unexplained RPL. Of course, in explained RPL, if there's a LPD, suspected LPD, you can give progesterone and HCG to do the luteal phase support. Or if there is a APS, you can use them as an immunomodulator. But in unexplained RPL, it doesn't have any role. Large randomized control trials are needed. What about immunotherapy? Again, systematic reviews have consistently found no beneficial effect of immunotherapy in unexplained RPL. Simply because you don't know what to do, you should not be giving all sorts of treatment to the patients. What about progesterone? Again, progesterone is somehow trying to make its entry everywhere. So, for as far as unexplained RPL is concerned, the PROMISE trial has clearly told us that progesterone supplements in the first trimester of pregnancy do not improve outcomes in women with history of unexplained recurrent miscarriages. Of course, again, it tried to make an entry through vaginal micronized progesterone. And this particular study or publication showed that it is more effective than placebo in reducing the risk of miscarriage if administered in the luteal phase of the cycle in women with history of unexplained pregnancy loss, RPL. But this article has been retracted since March 2020. So I do not want to suggest this for as a treatment for unexplained RPL. What about TLC? Tender loving care or therapeutic lifestyle changes? Of course, we can give that in plenty when there is no other thing to offer. Improving psychological well-being. Yes, a research study is currently running in Southampton and Portsmouth Hospital, evaluating the role of improving the psychological well-being in women who have suffered recurrent miscarriages. Carry home, as far as unexplained RPL is concerned, no immunotherapy. It has got grade 1A evidence. No glucocorticoids, again grade 1B evidence. No progesterone, grade 1B evidence. You can start with simple, low risk and less expensive interventions and then go on to, if unsuccessful with the simple ones, then go for complex, higher risk and expensive options like IVF, PGT, donor egg, and surrogacy. Thank you so much for your patient listening.